doctors and esteemed guests, it's an immense pleasure to stand before you as a representative of Aristo Pharmaceuticals Private Limited to this sought-after seminar in otolaryngology. As we gather in this holy place, Ayodhya, which has not only become the beacon of Hinduism, but also a very, very historical town, which is known for its integrity and developments. I feel very proud when I see the culmination of the relentless effort done by our field, and when I see 300 kilometers distance to come here to attend this seminar, and trust me, it is a matter of pride for us. We know that most of you are the leading practitioners in your respective towns, and it was not easy for you to sacrifice your 2 days practice and come here. I once again thank you on the behalf of our organization, and I assure you that the feast of knowledge that we are going to serve you here, and also mixed with our hospitality, every second you spend here with us will be worth it. Respected doctors, I would like to bring forth to you the faculty that we have got for you over here. The faculty is cherry-picked because this seminar was very, very important seminar, because this is the first in-house seminar which we are doing in otolaryngology. And the faculty that we have for you is a truly luminary in his field. And I tell you that the contributions that he has made to the field of otolaryngology is nothing but awe-inspiring. It is my pleasure to introduce to you our faculty for the day, respected Dr. Madan Kapre. May I request Dr. Kapre to take his seat on the dais, and may I request our All India State Head, Mr. Prem Raj, to present a bouquet of flower to respected Dr. Madan Kapre. Thank you so much, sir, for coming, for gracing the occasion. Respected doctors, Dr. Kapre's contribution to the field of otolaryngology, as I told you, is nothing less than awe-inspiring. And that will get evident when I read about his credentials and his contribution to the field of otolaryngology. I'm sure that once you listen to Dr. Kapre, the way you approach his expertise is going to change from tomorrow. Dr. Kapre hails from Nagpur. He has an experience of more than 46 years in managing the patients in the field of otolaryngology. He is a director of Niti Clinics Private Limited in Nagpur, and some of the international affiliations are that in 1984, I was just 10 years old then, he was a consultant in the Trans-Regional Area Authority in UK. Thereafter, in 1985, he was a consultant ENT and the HOD in Omizia General Hospital, Saudi Arabia. He has been the advisor Asia Pacific Thyroid Society in 2018, and he has been the founder and governing council member of Asia Pacific Thyroid Society. He also has been the team leader India Forum in the WCTC London 2019 and 2023. So quite a lot of international affiliations credited to Sir. As far as his national contributions are concerned, he has been the founding president of Indian Society of Thyroid Surgery. He has been the president of Indian Academy of Otology, Head and Neck Surgery. He has been the founder member of the Foundation of Head and Neck Oncology of India. He has been the treasurer of Foundation of Head and Neck Surgery for almost 3 years in continuation, for 2003 to 2005. Secretary of the same association for again 2 years, 2005 to 2007, and the president of Foundation of Head and Neck Oncology from 2011 to 2013. Sir has been the founder governing council member of the Asia Pacific Thyroid Society, Seoul, and has been the founder president of Laryngology and Voice Association of India. So quite a big hand in lot of associations as a governing council member. As far as the contribution in the publication is concerned, a chief author for many books like Atlas of Thyroid Surgery, Atlas of the Surgery of Trismus of OCMF, Essentials of Head and Neck Surgery, and the Principles of the Practices of Thyroid Surgery, all by the leading publications of the India and international. In terms of his author as a contributory author, he has been contributing in the books like Endocrine Surgery by the Indian Society of Endocrine Surgery, Atlas of Otolaryngology, and Textbook of Otolaryngology. Very interesting to mention some of the special social awards that Dr. Kapre has been associated with. He has been getting these awards. I must tell you that his contribution to philanthropy and to the charitable work, especially in the backward field, in Adivasi areas, has been noticeable. Since he belongs to Nagpur, all of you must be knowing that there are a lot of Adivasis around Nagpur. So he has got the Service Above the Self Award by the Rotary in 2006, which is the highest service award in Rotary International. He has got Jeevan Gaurav Puruskar, again for the tribal work by the Bharatiya Adim Jati Sevak Sangh, and he also has got Adivasi Mitra Puruskar for the same tribal work by the Bharatiya Adim Jati Sevak Sangh. 5 years, 5 days every year, Sir is devoting totally to the free of cost surgery to as many people of backward classes as possible for all kind of surgeries in otolaryngology. And for that, lot of charitable work happens, lot of philanthropy happens, and right from the home of that poor person, and after the surgery back to his home, his food, his lodging, his OT expenses, everything is beared by the association that Dr. Kapre is associated with. So I have a great pleasure in inviting Dr. Kapre here to take you through his deliberation. Today is a very special day. Today is a World Thyroid Day, and he is going to deliberate on the topics of thyroid surgery. So that also makes this symposium very special. Also, there is very interesting thing that I like to share about Dr. Kapre. Cricket is his passion. Cricket is his religion. And he has been the president, he has been the very important post holder for many, many years in Vidarbha Cricket Association, which is one of the most noticeable and renowned cricket association of the country. He has also been playing cricket internationally in UK, and he attributes his career success to his success in cricket. And I'm sure he'll be very elated to share the stories when you meet him after the symposium. And also I would like to mention, tomorrow is tomorrow is a IPL final, which is also a very, very important occasion for cricket lovers. And Sir has agreed to sacrifice that because he's coming here and he will reach Nagpur only tomorrow night. but still he agreed, which talks about that his love for knowledge dissemination is bigger than his love for cricket. So it's a pleasure to host Dr. Kapre here. Sir, big hands to you. Thank you so much on this very argumentous and auspicious day. Please come and enlighten everybody. Thank you. Before that, sir, lamp lighting. Yeah. Oh, yes. Before that, sir, I'll request you to light the auspicious lamp. I request Mr. Mishra and Mr. Premraj to join Dr. Kapre for lamp lighting.
We start? Well, at the outset, I pay my humble respect to Ram Lalla, because I think Ram Lalla got me here. I mean, of course, I am a son of a primary school teacher, so if it's come to teaching and sharing knowledge, I'm always eager. But more than that, it had been a dream come true for me to be in Ayodhya. And as much as I was looking forward to today's talk, I'm equally excited to go to the mandir tomorrow morning. So thank you all very much, particularly the team. And with my respect to this is a beautiful, I mean, you cannot stop looking at it. And the more I look at it, the more you get attracted to it, and you start seeing different facets. And your emotions fly, and if I say anything, I think I probably will not do justice, because I will fall short of words to describe the emotion that flows over me when it comes to Ram and Ayodhya. This elaborate introduction humbles you, almost makes you feel कि अभी घर जाने का time आ गया. But believe me, अभी time नहीं आया. The next thing I'd like to share with you is distributing knowledge. Is हम लोग कोई भी फंक्शन के पहले सरस्वती वंदना करते हैं, लैम्प लगाते हैं, उसके पीछे क्या है? बहुत सेल्फिश मोटो होता है हमारा. यहाँ से संस्कृत में जो सरस्वती के शुरुआत के है, उसमें जो लाइनिंग होती है, किसको आता है? मैं बताऊंगा उसमें कैसे होता है. चार हार धवला या श्वेत वस्त्रावृता या वीणा दंड मंडित या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभुतिबीर देवई सदा वंदिता सामाम पातु सरस्वती भगवती निशेष जाड्यापहा. तो हम सेल्फिश क्यों बोल रहे? हम पहले सरस्वती को बहुत तारीफ करते कि तू इतनी बड़ी है, सारे भगवान तेरे को मानते हैं, तू इतनी सुंदर है. बट एक बात करते करते धीरे से पीछे क्या बोलते बाद में, सामाम पातु सरस्वती भगवती निशेष जाड्यापा, कि मेरे का जड़त्व हटा दे, मेरे को हल्का कर दे, मेरे को अज्ञान हटा के ज्ञान दे के ऊपर उठा. तो मे बी टूडेज मीटिंग विथ ए वेरी ऑस्पिशियस वे ऑफ लाइटिंग समय विल प्रोबेबली होप टू सी. And because I am in Uttar Pradesh, I cannot also share something in Hindi on the same thing. माँ सरस्वती की दरबार की कुछ अजब गजब सी बात, ज्यों ज्यों बांटे त्यों त्यों बढ़े, ना बांटे घट जात. So I think every time I give a talk, I learn myself, I study myself, and I enrich myself even more. So with that much of prelude, I come back to the topic of thyroid surgery. When the thyroid surgery started, would you believe that the surgeons were not allowed to operate upon thyroid? हम लोग Langenbeck's retractor बहुत वापरते हैं. Anybody knows Langenbeck right angle retractor, अलग अलग shape? Do you know that that man was jailed for operating on thyroid? They were complete. And this Samuel David Gross, जिसके आप पढ़ रहे हो, क्या बोलता था वो about thyroid surgery? His reputation was, unless the tumor was fixed to the operating table, he will remove it. That was how aggressive Samuel David Gross was. And yet, this is what he said about thyroid surgery. And very proudly I can say, in today's day and age, we even do not cross-match the patients when we take them for thyroid surgery. We have come so much way further forward. Now, my whole interest in thyroid surgery began so many years back when I was faced with big Adivasis with massive goiters. And believe me, when I did my FRCS in England way back in early 80s, the thyroid was not in the realm of ENT surgeon. I had never seen thyroids, not so big. So it was a challenge, and I started sort of rising up to the challenge, and I said, let's do it. And I started learning, literally, opening the book, and I give my respect to a gentleman called Professor Dr. Ram Mohan Tiwari. I don't know how many of you know him, but he literally took my hand and showed me the way, step by step. And the first surgery we did was, he was operating on one table, I was operating on another table. He would complete one step on a closed circuit monitor and said, "Samajh gaya beta?" And when I say not diya, so he'll go to the next step. So literally step by step, but from there onwards, it became, and the world started noticing us. And I'm just showing this not to show off what I'm doing, but to tell, if you do good work, no matter where you do good work, you get noticed. And on the left, there is a professor of, and the only professor of thyroid surgery from UK, Neil Tolley. At the bottom, you see Greg Randolph. Greg Randolph's a book everybody reads on thyroid. All these guys have come to Chikhaldara, which is the Melghat belt where we work, because the word spread so fast that if you do good work, they want to know what you are doing. And in the middle, there are two great giants of the American head and neck, Jatin Shah and Ashok Bhai Shah. That led to publication of 4 books, and I'm so proud to say that each picture that appears in those books comes from Melghat. They are not my Nagpur patient, they are not from anywhere else, but every single picture you will see in those books is from that area. Having said that, I would like to add very hastily, everybody nowadays loves thyroid. Anatomists, pathologists, everybody. Why? Because thyroid is one such area, whatever you do, you cannot go wrong. If I do a patient and do a hemithyroidectomy, this much portion of the audience will support me for doing it. This much portion of you oppose me for, "Oh, why have you done hemi? You should have done total." That guy will say, "Oh, total is sufficient." No. Hemi is good. Because there is such a huge controversy. Number 2, excellent prognosis. If you are my age and you operate upon a CA thyroid, your patient will definitely outlive you. You will join your maker much before your patient goes up there in the heavens. And that is because whatever you do, it has got 96% plus success in thyroid surgery, no matter what you do. Excellent fallback. Even if you leave something behind, I-131 will take care of it, most of the time. Above all, every cancer that you know, if there is a lymph node metastasis, your prognosis goes for a 6 by 50%. But thyroid is one condition where nodal metastasis has no impact whatsoever on the prognostic or the survival of the patient. It's a wonderful disease, so everybody wants to do it. And therefore, all these people come to the round table when it comes to thyroid. But I must hastenly add, each one of them has contributed enormously to the modern day thyroid surgery. Explain to you. You must all heard Galen and Galen's nerves, recurrent laryngeal nerve. Now, how did he first explain this nerve was supplying the vocal cords? Any idea? He used to operate on pigs and demonstrate that if you cut one nerve of the pig stops shouting. He becomes quiet. But if you cut both the nerves of the pig dies because he can't breathe. Because one cut nerve causes unilateral laryngeal palsy, both nerves cause backbreather palsy, and the pig dies because he can't breathe. See, such a small thing he did, but now today we know exactly what exactly happening about the recurrent nerve and all that. So I also am a deep appreciation for all those people who are coming in. And here I take a little time off to say that today is a World Thyroid Day. Now, why should we celebrate such days? Today we are celebrating the World Thyroid Day, partly one reason that we are coming of age in thyroid surgery. Whatever we did about, say, a decade ago is not what we are doing today. And this is because the information or the dissipation of information, shall I say, is so rapid across the globe. Whatever happens in New York, whatever happens in London, whatever happens in Japan is talked all over. Now today is a time when we got a lot of controversies. In Japan, even a 5 centimeter tumor of thyroid, we still do hemithyroidectomy. I mean, they do hemithyroidectomy, we don't. On the other hand, across the Pacific in America, even if there's a 2 centimeter nodule, they will go for total. One hand, Ito says that if there's a 1 centimeter cancer thyroid, don't need to operate, observe him. On the other hand, if you and I get a 1 centimeter nodule with a thyroid cancer, we'll first look for a surgeon who's good and get it operated. So because of this, it's important that all of us, in particular those who are dealing with thyroid condition, are aware. Up-to-date knowledge is important, and I take this opportunity to dissipate that knowledge or that information that I have gathered over the years with all of you today. Now, before we begin into the thyroid surgery, let's see what is adequate surgery. What do you call adequate surgery depends upon your own expertise and your own philosophy. What may be adequate for me may not be adequate for you. But that's not the issue. The issue comes when we have a wonderful quote, when you all operate in the best of the interest of my patient, I did this. Many times, put your hand on your heart, it is actually your own interest. It is not the best interest of the patient. Be honest about it. And I'll tell you a story of my own self. When I was doing my MS general surgery, we were repairing the hernial sac. With the same sac, we used to put that into boiling water, destroy all the epithelium, just get the fibrinous sac material and repair that like a darning, like you'll use mesh nowadays. And we convinced our patient that that was the best method. And how long did that best method last for? Until I finished my thesis. And never after that, and you would have never heard of it. But my professor and I did convincing my patient, very cheap, very nice. वहीं के वहीं हो जाता है, 5 मिनट के अंदर हो जाता है. But that all was convincing my patient because I was pursuing my interest, not patient's interest. So that's one thing we should be very careful and not get into. Getting the language right. Lots of words are used. Lobectomy, partial lobectomy, isthmusectomy, hemithyroidectomy, subtotal thyroidectomy, near total thyroidectomies. Where do these words come from? These words come from the potential fear of damaging the recurrent nerve and the parathyroid glands. So at one point of time, in order to be safe, that you are not damaged the recurrent nerve and you are not damaged the parathyroid, you just left some part of the thyroid gland at the posterior aspect like a slither and call that operation as subtotal thyroidectomies. Sometimes, because you are afraid to lose both thyroid and parathyroid, you removed one side completely And you said, okay, उस साइड का nerve गया तो कोई बात नहीं, दूसरा nerve बचा के रखता हूँ. And then that operation started being called as a near total thyroidectomy. Very arrogantly, the guys you saw on the picture earlier on, you know what they say? The subtotal thyroidectomies or near total thyroidectomies are done by subtotal thyroid surgeon and near total thyroid surgeons. Arrogant that statement might sound to you, but it's very true that there are only two nomenclatures that should exist in thyroid surgery. One nomenclature is hemithyroidectomy with isthmusectomy or total thyroidectomies. There are no other words or there is no other surgeries to be performed. This is a very mundane looking thyroid. I mean, you have seen it every day in and out. It doesn't worry you. It doesn't worry anybody. कुछ भी करो, दाएं हाथ से निकालो, बाएं हाथ से निकालो, कैसे भी करो. This patient is going to be very good. But look at this. What has now changed? The patient has got a beard. The patient is probably in 40s. And suddenly it's no more a mundane thyroid. It becomes a potentially cancer thyroid. And therefore, the attitude, the philosophy suddenly changes. And therefore, I'll start talking about first the benign condition, which was the first picture, and then the cancer, which was the second picture. I will talk about all these things little by little and tell you precisely where we stand in respect to what we should be doing. Thyroglossal cyst and the aberrant thyroid. We meet them every day. And the investigation that you should do minimum is to do a ultrasonography of the neck to ensure that the normal thyroid gland exists in the neck, and what you are going to remove as a thyroglossal cyst is not the only surviving or only thyroid tissue for the patient, because it will doom disaster if that was the only thyroid and you remove it. So therefore, the minimum investigation I would say is to do an ultrasound neck. Would you do FNSC all the time? Not necessary. But if that patient happens to be an adult and you are convinced that this is a thyroglossal cyst, I will insist that you do FNSC, because although rare, very often you will find that in that cyst there is a papillary carcinoma. Because this guy who rose to the level of 30 years plus had that cyst but never troubled him, but something happens, it starts growing, and that is the papillary change in the thyroid tissue there. And the operation that you will perform will be nothing less than a cyst trunks operation. It has been often sadly seen that somebody removes it like a little 2 minute ka kaam hai bhai, aa jao, kar denge. They remove that thyroglossal cyst and the patient recurs. And the second time you want to operate, it's a mess, because you never see the track, you never see anything, and you arbitrarily remove the body of the hyoid and convince yourself that you have done a good job, but you will be having always the trouble, and be aware, ऐसा करना पड़ा तो हो सकता है कि you will be the second, third and go on. So best is the first operation, and the minimum you do is a cyst trunks operation, which is the cyst, the body of the hyoid, and chase the track right into the base of the tongue. Puberty goiter. Often this condition, although common, you will be pushed into corner for doing something, because the girl is teased, there is the issue of cosmesis, there is the issue of people noticing her. Please refrain from doing anything. If that girl is euthyroid, that means she is not hypo, there is no need to do anything. Unless cosmetically you see the girl at the top there, the physiological goiter occurs at the menarche, it occurs during pregnancy, and it can sometimes occur at the menopause also. So this period, if they are not worrying cosmetically, no need to do anything, except the girl on the top, it will be probably better to put her on exogenous thyroid so that her own thyroid is suppressed and cosmetically the girl is able to attend the school and the college and the lot. Inflammatory conditions of the thyroid. I will tell you one thing. How often in your OPD busy practice you have people coming, गले में कुछ फंसा फंसा लगता है, lump लगता है, गिटकता हूं तो दुखता है, and you all call them globus, you call them GERD, you call them LPR, you call them psychiatrics, you put them neuralgia, but from tomorrow, just try to palpate their thyroid and ask them to swallow when you put your hand firmly on the thyroid, and about 1/3 of your patient will wince. The face will go, Dukha doctor, and they are actually very low-grade subclinical thyroiditis, and they often present as vague symptoms of pain or dysphagia. Treat them appropriately and you will have a bingo. Because many times these patients have already seen 3, 4, 5, 6 doctors before you, and you get the diagnosis right and you become a hero. Hashimoto thyroiditis. I am afraid you are often tempted to operate, but never, ever, ever, never, if possible, do not operate. Reason being, they look very hard. You may be almost feeling whether this is a lymphoma, whether this is malignancy, but if it is a Hashimoto, the ultrasound or the CT scan will give away the diagnosis. No matter how hard and how nodular the gland looks, it is uniform. And the reason why not to operate is because this gland is exceedingly vascular, there is a lot of scarring, and you will be totally committing a mess and get yourself in all kinds of trouble. Best is not to operate sooner or later. But how much you treat them? If they are toxic, if they are in pain, if they have got a lot of symptoms, no matter what the endocrinologists say, my own policy is I treat them with steroids and I treat them with suppression therapy. And the reason being, you want to rest the gland. The less the activity of the gland, the better are the results. So put them on exogenous steroids and also put them on, exogenous thyroid and steroid and supporting painkiller, and often they are good. Inflammatory conditions. Post-viral, this is common, but don't forget this condition, because the books don't mention this. Tubercular thyroiditis does exist, because our country, unless put otherwise, a lot of these neck nodules are tubercular, and I have seen quite a few of these conditions where they keep going from pillar to post, and all that they need to do is to put them. Diagnosis is very easy. Such kind of ulcer, take a little biopsy, it's not a brainer. This condition, Graves' disease, although the books will say that don't ever operate, there are times when you need to operate. And the only surgery you perform for them is total thyroidectomies, nothing less. Now, this is one young girl who wants to get pregnant. She is not getting control adequately. She doesn't want to take radioiodine because she wants to conceive. I think these kind of patients are the ones where you may consider surgery. Try to get them beta block, try to get them as stable as possible. And the pearls in surgical technique is, please do not ever be ashamed to cut the muscles. Because you don't want to struggle with retraction, you don't want to put big forceps and yank on the thyroid, because that process may deliver the thyroxine into circulation and you can get a storm. The second care is, you always ligate the veins first, block all the veins first. So even if you handle the thyroid gland, the thyroxine will not get liberated in the circulation, and the dreadful condition called thyroid storm may not or will not happen. These conditions, metabolic active nodules, say one on the right hand side, that young lady is good. You got one active nodule, you can remove the nodule and bingo. But what about the second lady? She has a multinodular goiter, and one of those multinodular goiters is active. You may roughly get where it is by doing a scan if you like, but to my books, such patients are best dealt with a total thyroidectomy. This condition, I am very sentimental about this, because you see a lot of patients with toxic orbitopathy, or we call exophthalmic goiter, and they get pillar to post. The endocrinologists do not know that there is a very simple thing called decompression endoscopically can alleviate that symptom. And I vociferously campaign and try to speak to as many ophthalmologists as possible. Let this patient not become blind because of sort of a keratitis or ulcers, or ultimately land up with no vision because he doesn't know that we can decompress the orbit and give that man a perfectly normal vision for years to come. Multinodular goiter, I call them common garden Chikhaldara goiters. Whatever the book says, you cannot do but a total thyroidectomy here. There's no reason why not to do. Now, there may be some clever person may say, oh, but she's an Adivasi, she is very poor, she may not take thyroxine. What if you do a hypoparathyroidism? The thing is, if you actually ever operate, you cannot think which part of this gland am I going to leave behind. There is nothing technically speaking, number one. And number two, whatever you leave behind may not be the functioning part also. And the third thing, if that becomes nodular, you had it. So probably train yourself well to know where the nerve is, train yourself well, know where the parathyroids are, and go for total. Compressive thyroids. Now this lady has hardly anything to see in the neck, but her most of the thyroid is sitting in the superior mediastinum. Now simple Pemberton signs, simple arm raising up there, or simple history. Can you sleep at night in a normal supine position? And if the woman says she can't, that means she has got a pressure on the trachea and you need to elevate that. Whether it will come through the neck or whether it need to be a sternotomy or some sort of a chest approach, the rule is very, very simple. First is a clinical, that you can dip your fingers underneath, but that may not be necessarily always true. But see what is the transverse diameter of this vis-a-vis the opening of the superior mediastinum. If that is bigger, you can always be assured. Now, I am lucky because I got a good friend of mine who is a thoracic surgeon, and he is happy to let me operate such cases into his situation, his clinic or his surgical OT, and I can get away. But I can tell you, 9 out of 10 times, we don't need him. Because most of this will come. The trick of surgery, what helps you to bring it? Remember, if it is benign, it will almost certainly come out. Reason being, the benign retrosternal goiter carries its own blood supply and carries its own capsule in the superior mediastinum. Whereas a malignant thyroid may have adhesions and may have blood supply coming elsewhere in the mediastinum, and therefore that's a different ball game. Don't attempt to remove a mediastinal goiter which is malignant. But benign, just turn the table a little bit down, cut all the muscle, cut all the fascia, put the nerve on one side and gently say prayers, and the thing will come out through the neck almost certainly. This is going to happen more in the future, which is called incidentaloma. Somebody does a cervical spine, maybe oral cavity, maybe idiopathic neck pain. Somebody will do ultrasound, somebody may do MRI, and they will come up with a nodule in the thyroid. Now, what do you do with these so-called incidentalomas? My attitude or my philosophy is, you treat them as if you have palpated them. You treat them as if you have seen them or felt them, and treat them on their own merit. Now, Ito says you can leave them. But well, our patients are not Japanese. Our patients keep not coming every 4 months for every 4-monthly scan for them. And thirdly, if I ever knew, or anybody of you knew, that you have a cancer sitting in your thyroid, how comfortable will you be to be there and not do anything about it? So therefore, I treat incidentaloma as if I have palpated them. When I get suspicious about these nodules, females above 45, girls below 15, and men, I look into clinical. What are the red flags? The red flags is pain. No matter how big the thyroid is, a nodule or a goiter is, it is never painful. So if the goiter is painful, there is a sudden expansion. Pain means that nodule has suddenly started expanding. So the capsule has become tense and caused pain. So that means there is something wrong there. Hoarseness is very obvious. Dysphagia, be careful. Not all cancers dysphagia. Many benign nodules can cause dysphagia. When the nodule is sitting posteriorly, and when nodule is sitting in the TO groove, even a benign small nodule can give that particular feeling of something moves up and down or I can't swallow. So not all the time. Size, of course, the bigger the size, the more the chances that this is malignant. Sounds simple to you because all of you are otolaryngologists. But do you know one interesting thing? How many general surgeons, how many endocrinologists, how many so-called head neck cancer oncosurgeons do a pre-operative indirect laryngoscopy or a post-operative indirect laryngoscopy themselves? Any idea how many? It's an official paper, and I can quote you that paper. Less than 25% do indirect laryngoscopy on the vocal, which is so important, and they go away by the voice. And just to break the story here, I had a young girl of 22 who had absolutely normal voice, and I was invited to operate on this girl into somebody else's clinic because I was up and coming and I was like a jidhar bulaya udhar main aa jata hu yaar, kya kar deta hu. And I did that surgery there. And at the time of surgery, we found that the nerve was actually going through the tumor. So in all honesty, I went outside and talked to the relatives that, very sorry, but she will have a bad voice at the end of the surgery. We have to sacrifice that nerve, but the other nerve is good. Voice will come back. Jokingly, her fiancé was in the audience. I said, your wife may have a very husky but maybe very sexy voice, and she may speak to you like this for a while. Come out of the OT, her voice was absolutely normal. And everybody thought I was a magician. डॉक्टर साहब आप तो बोले थे आवाज बैठ जाएगा, भगवान की कृपा है, आपके हाथ में शिफा, I mean all that kind of a dialogue. ये तो आवाज बिल्कुल सही है. No, was I really with a God's hand there? Like Sandy Diego, the footballer, Maradona? Did I have that blessing in my hand? No. Actually, I was an idiot. I was wrong. I did not have that. The patient had a very slowly, insidiously occurring recurrent nerve palsy. She had already compensated. So by cutting that nerve, nothing happened. So be very careful. Normal voice doesn't mean normally functioning vocal fold. Now I'll just briefly go. I know you are probably not into so much of cancer surgery, but I'll just brief you on the planning or the philosophy of management of cancers. In thyroid, there are three. How many of you are my age here? I mean, 70, 65? How many of you know these three guys? The good, the bad, and the ugly? Clint Eastwood is a good guy. Eli Wallace is a bad guy. But Lee Van Cleef is a dirty guy, an ugly guy. And this is a famous picture, the good, the bad, and the ugly. Like that, the cancers are the good, the bad, and the uglies. On one hand, there is a good cancer. And that good cancer, you do whatever you want to do, the patient does wonderfully well. On the other hand, there is an ugly cancer, which is an anaplastic or poorly differentiated variety, and that fellow, do whatever you will do, he will not do well at all. And you will have a patient who you will miserably fail to do good. And that's because of this. On one hand, there is a differentiated cancer, which almost 96% cure rate. On the other hand, you have got an anaplastic cancer, which the patient don't go beyond 6 months no matter what you do. So therefore, it is very important that if you are dealing and knowing the cancer thyroid, please try to put them into perspective, whether they are the good ones or the bad ones or the ugly ones. Now, papillary thyroid cancers, by and large, is a good one. It has got excellent prognosis. Usually, you can know them by size, but be aware that they always come sometimes with large nodes. And I have seen patients being opened up for branchial cyst. I have patients opened up for diagnostic lymph node biopsy, and that turns out to be a papillary carcinoma lymph node, and you should be very careful in always getting them right first time. The thing is that they are multicentric. Now you will have lots of thyroid cancer people, and I can say I have been through that circuit myself several times. People vociferously arguing, अरे opposite side का thyroid कुछ नहीं होता है, रहने दो, हेमी करो. I mean, who gives you guarantee that the other side node will never ever grow? And that is a laboratory cancer. Let Ito and the company, Yakamushi and all those guys from Japan say, never trust it. See, there is a big tumor on one side, but the other node also has a cancer. The follicular cancer is not that bad one, but I will not say it's a good one. It's an intermediate one. And the reason why it is a good one, sorry, not a good one, but the bad one, they spread very quickly. And they very spreadly, hematogenously are in multiple places. So be careful with that. Consent. You see, if you're going to change your direction in the middle of the surgery, like that tumor is not big. See the petri dish? It's not a very big tumor. It's about the same size as the thyroid gland. But the tumor is placed so laterally and out that there is no thyroid tissue outside it. So even a small tumor can become a big tumor as far as management is concerned. And therefore, when you take a consent that you may do more surgery than just what you have planned off to do a hemi or whatever. And the second is, don't fight with your pathologist. You see, as a surgeon, I always jokingly say, you should marry anesthetist. And some say, no, it's a pathologist. No, it's something sonologist. कितने लोगों से शादी करोगे? But the thing is, if a pathologist says that he cannot diagnose follicular carcinoma, don't shoot him, because they can't. And therefore, that is one condition where you will need to revise your own plan. Now, this is a very confusing thing. Do you know there are 18 different types of risk stratification for thyroid cancer? But what's the catch? The catch is that a lot of this information is not available firsthand. The tumor differentiation, the final histopathology, the variation, tall cells, sclerosing, you don't know all this before you start. And therefore, it is important that you go by some other method. And when this came, we started analyzing. It was my daughter, Niti, who put her brains together, and we have come up, and I'll spend a little more time on this area because this is very close to us. This is something which we try to answer about the risk stratification in thyroid cancer. My son-in-law, Dr. Abhishek and Niti, they put their brains together, and we come up with what we call as an impact study. What we thought we'll do, that on one hand you have got ultrasonography, and they have got the TIRADS method of classification, 1, 2, 3, 4, 5 and 6. On the other hand, we have got a FNSE, which is Bethesda, 1, 2, 3, 4, 5 and 6. Then we add one more dimension to it. And that one more dimension was actually us. What did we feel of it? And we sent a sort of a questionnaire to around well into 200 surgeons that we knew, and we asked them, when would you call that a cancer, clinically? Was it pain? Was it recurrent nerve palsy? Was it dysphagia? Was it one nodule or multiple nodules? Was it neck nodes? So we gave them question, and they answered us back. And we had one more dimension to it now. What does the clinician say? And then we put them all on one basket, and we talked to the pathologist. What did he think of it intraoperative? We called him to the OT and we cut this thing in front of him. And then we also had the final. And we put all this together. And we started looking at, can we come up with something which will answer our question of risk stratification, the Indian way of jugaading. So that's the Indian jugaad now. So we have got what we can call our suspicious index, or we call them as a integrated score. That integrated score was when we put all these facts together and give them marks. For example, if the clinician said that the patient has a recurrent nerve palsy, 100% cancer. If the clinician says it's painful, 100% cancer, like that. And then that integrated score was on one side, and the other side likelihood ratio. For example, what's the likelihood ratio that if I have a tumor in my thyroid, I'm likely to be cancer? Simple. And that's statistics. So many percentage of the population. And you put these two things together, and we got the predictive nomograms. I mean, the breast has got a nomogram, the ovaries got a nomogram, but there is no nomogram for thyroid. And we have attempted to give this nomogram, and Niti presented this paper twice, once in World Congress in Boston, and then one more time in London. And it's been validated now, but as it always happens, the Indian data is looked upon with suspicion. We have got a great kind of a bias about us, but ultimately we showed this, and this is now being accepted. Let's see how it translates. 60-year-old female, FNSE Bethesda 4, ultrasound TIRADS 4A. This is all kamsi kamsa. Ho bhi sakta hai, nahi bhi ho sakta hai. Then we applied our pre-test probability, and the index was 0.46. Likelihood ratio was 40, very high. And then we put them all together, and it came to 97, 0.97. And then there's a graph. This is a little bit statistics. It will make it easy. And once you put that, the says, yes, this is cancer. And ultimately it turned out to be cancer. We are trying to even more simplify it so that it can be used on a day-to-day basis by most of the people. But now coming back to the final few slides of my presentation, we get with this technique high-risk tumor, low-risk tumor, high-risk patient, low-risk patient. Now let's see, if it was a high risk on any side, it is very simple. High risk means you go for total, whether it's a tumor or a patient. Low risk, very simple. You go for less, which is hemithyroidectomy. But what do you do when one is high risk and the other one is low risk? And that's the discussion will never come to an end. We will have 1 glass of beer, 2 glasses of beer, fight like dogs, go home, come back and fight the next day. Because people will never agree upon that, and therefore, although this sounds very simple, optimal surgery is not yet resolved. For that, we have Indian data. Ketan, are you aware that we have guidelines? Indian guidelines are there. See, we had Japanese guidelines, American guidelines, European guidelines, but we did not have Indian guidelines. And that was a passion that I carried on my head when I started the association called Indian Society of Thyroid Surgeons. It way back 5 years ago. Now we have our own guidelines. If anybody is interested in knowing what are the Indian guidelines, you can either go on net or you can ask me later on. Now, why do we do total thyroidectomy? Or why do we do hemithyroidectomy? There are arguments on both sides. But put the arguments at rest, I will come to straight meat of the story. How good you are to do either total or you do hemi. How confident you feel that your patient's recurrent nerves are safe. How confident do you feel that you have seen the parathyroids and saved them? If the answer to this question, there should be honest answer from here. Yes, I am confident both nerves are safe. Yes, I am confident that the parathyroids are safe. Then I will say very strongly, please, please, go ahead and do total thyroidectomy for all your patients. But if any of these answers are question mark, or you yourself doubt as you are proceeding, Greg Randolph, the great big man of thyroid surgery from USA, professor of Harvard, and everybody reads his books. Do you know what he does? We can't do it in our country, but he does it. He actually stops operating. Can you beat it? He will do one side, stop, stage the operation, do the rest of the operation 3 months later. Because he says having a patient with bilateral palsy or bilateral parathyroid hypoplasia function is a bigger disaster than leaving a patient with the other side low. We can't do it. But at the same time, we should keep that even the big man gets into trouble and he is candidly honest not to do total whenever or wherever he is in doubt. As a thyroid surgeon, I show you this picture many times, those who have heard me talking. On the top, I was very happy to say that the recurrent nerve के पीछे से inferior thyroid artery की एक branch आके thyroid में जाती है. I was very happy to say that. And that was in the year 2000. In the year 2005, I said that there is one more artery that runs parallel to it. And I was even more happier. But my graduation was not complete yet until I saw that picture in 2007. That means there is a vascular loop, the terminal branch of the inferior thyroid artery, anastomosis with the final branch of the superior thyroid artery, and then together they supply the parathyroids. We graduated even more, which is coming out in another 3 months' time, in the paper when we are going to call inferior thyroid artery, not inferior thyroid artery, but call it as a parathyroid artery. Because we are going to prove it very quickly with all anatomic dissections of cadaver as well as live, that inferior thyroid artery is the sole supplier of parathyroids. Wait for that paper to come out. But until then, you respect parathyroids and recurrent nerve and don't do total unless you are forced into it. Now I just wind up by saying parathyroid, follicular carcinoma, medullary carcinoma, do as much as you can in first go. Because there is no other treatment for medullary carcinoma than surgery. Surgery, surgery and more surgery. Children, don't be scared. They do wonderfully well. This boy is an adult. He has his own children and they all call me grandfather. Because they may look very bad, but they do extremely well. Even the pulmonary metastasis, they melt away like butter on radioiodine. So don't get panicked with a small child with a papillary carcinoma, they do well. Pregnancy. If the pregnancy is precious, don't be in a rush to operate that lady. Let her deliver and then operate. Nothing is going to go wrong. Thyroid lymphoma, they do cause problem. And this is the only one condition where probably there is no surgery, obviously, but you may be justified in doing a true cut or more tissue obtainable by any other method to get just the biopsy. But surgery, definitely no. They melt away like butter. I remember one lady came in Strider. We thought we almost lost her. Huge thyroid, and we thought lucky would we be if we can get a small tube in. We did get a small tube in. We put her on steroid. Come next day, we didn't even recognize her. So they do magically well on steroids, and then you can manage. Don't touch this fellow, no matter what happens. You may get any amount of money, don't touch him. Now this is the last slide, or last but one slide, NIF-TP. This is a new kid on the block. And a lot of American thyroid surgeons got into trouble because New York Times presented this paper on the front page. Doctors got it all wrong. They were operating patients who did not have cancer, thinking they have cancer. And that is a non-invasive follicular thyroid neoplasm with papillary-like nuclear feature. These are cancers, but they are non-invasive cancer, and you are justified in doing a hemithyroidectomy. My question to you will be, but how will you know that before you operate? And therefore, again, there you go. You will end up doing follicular, you end up doing total, but don't feel too bad about it. Everybody. Neck nodes don't matter, I mentioned that. Pattern, I'll just go through. This is the picture you like to see in a neck node for a thyroid. Save everything. The great auricular nerve is saved, accessory is saved, sternomastoid is saved, jugular is saved. Just do a compartmental clearance, and that is good enough. Extrathyroidal spread. This is one cancer again, where you can probably shave off the tumors from the trachea. Don't be in a haste to remove a lot of larynx and trachea. You can do shave resection and save your patient. Distant metastasis, if they are solitary, you can consider surgery, but if not, even radiotherapy or radioiodine does excellent. Now, last slide, this is in honor of my wife, and I'm happy she's here to listen it. She does this wonderful technique of cervical epidural anesthesia. This is an excellent technique for the Meghat Adivasis we operate. You can see that she is putting a needle at the nape of the neck. Those who might want to, she is here, so you can ask her there. And then the patient literally walks on the table with a catheter in the neck and being topped up from time to time. Sometimes we go up to even 2.5 to 3 hours also. They are very comfortable. End of the surgery, they come down, she feeds them with a little bit of water on the table itself, and they just got off the table and walk off. But these are horses for courses. This is not a surgery that I will be doing in Nagpur. This is a surgery we will be doing only in Meghat, because those patients are very sturdy, very hardy, and they can be like this for no matter 1.5 hours, 2 hours, and they're ever so grateful that they got some surgery done. But I cannot not complete my talk without showing this slide, because this is a magical slide. And this happens about 12 to 15 times in 2 days' time. So it's absolutely mesmerizing to see these surgeries. And if that interests you, and anybody wants to do, you can join us in every year in January. We have an annual camp, and like Manish said, we go there for 5 days, and we do all kinds of general surgeon also. We do all kinds of surgery, but thyroid for 2 days continuously. I'll close by saying my concerns. One is thyroid cancer really increasing, or is it not true? Number one, it's probably not true, because you are diagnosing it more. A lot of ultrasounds are done, a lot of neck scans are done, a lot of people are aware that there is a cancer, which was not there probably in the earlier days. So probably we are just diagnosing too many. The second thing is too many cooks. पता नहीं आपके यहाँ क्या होता है, हमारे यहाँ पेशेंट सब सुना के आता है. But the most rascal of a cook is up there. Any guess who is there? Dr. Google. He's the biggest cook up there, because most of the patient, as soon as they will Google some blighter, not the patient, maybe his daughter, maybe his son, maybe his son-in-law, and they, isko to aisa karte, and they will all prepared. So if you ever see a patient in the waiting room with a laptop, be very careful of that bugger. Because everything you say will be double checked with Dr. Google, and Dr. Google is not always right. He's an American guy who's an extremely defensive medicine person. The last is your patient's financial status. If you got a patient who wear that kind of a shoes, you got to tell her, make your surgery for them. You see, you have to understand. See, on one hand, if you do too much, the patient will need to take calcium all their life. On the other hand, they will never come back to you again even if they get disease. So, weigh the balance correctly. Remote access surgery. This is now fanciful surgery is going. Thyroid is so good. God is good to us. Can you spot the scars in both? She is an air hostess. She is a big actor. Where is the scar? They both have papillary carcinoma thyroid. They both have gone total thyroid with neck dissection. Can't see the scar. So when you get such a wonderful scars in thyroid, I am very suspicious, very skeptical, maybe my age, about the so-called remote access. Lastly, politicizing thyroid surgery. How often you say, hey, जनरल सर्जन क्यों करता है, ये ईएनटी का काम है. वो बोलेगा अरे ईएनटी का थोड़ी काम है, ये हमारा काम है, वी आर ऑन्को सर्जन. एंड देन द एंडोक्राइन विल जंप इन. ये तुम्हारा दोनों का काम नहीं. दिस इज द एंडोक्राइन ग्लैंड. आई एम एंडोक्राइन सर्जन. दिस इज माय वर्क. डोंट पॉलिटिसाइज इट. डोंट बी अ क्राई बेबी. हमको दो, हमको दो, हमको दो. हम तो लैरिंग्स तुम रिकरेंट नॉर्म उड़ा देते हो तो हमको लैरिंगोप्लास्टी करना पड़ता है तो हम ही करेंगे. Not like that. Do it so well and do it so correct. And the last trick is put the fear of parathyroids and recurrent nerve in the minds of general surgeon. तो डर मर के वो पेशेंट तुम्हारी बात भेज देंगे. The catchword is don't demand it, command it. Lastly, the robotic surgery. I close my talk by saying, denying technologies like robots and endoscopes, you really cannot do it. Denying the technology will be stupid. But denying years of wisdom, of experience, will be even more stupid. That's my statement, and that's my take on robotic surgery. You're all very welcome to join the Indian Society of Thyroid Surgeons, and we have a meeting literally within 15 days in Calcutta. If you are interested, please let me know. It's an excellent feast for all kinds of knowledge for thyroid and more thyroid for 3 days. And at the last, again, Manish and full team of Aristo and all the people of Ayodhya and nearby. I'm told that people are from Banaras and they will come. And it's a dream come true for me. And I can't wait till tomorrow morning. I got a Aarti Darshan at 6, so I'll be leaving this place at 5 no matter what. But thank you all very much for my dream come true of seeing Ram Lalla tomorrow. Thank you. Yeah.
Any questions? Sir is here. You may ask. Mike, please.
You know, when there are no questions, either everybody has heard it several times and they're bored stiff,